Issues with overdiagnosis and underdiagnosis, and the long-term monitoring is usually poor. That is very sad. You can go and do a study if you like, and every physician, if it is primary care, those good folks don't want to deal with that because there's this narrative that it might conduct to abuse. And you Google it and you'll see all these structures, all for some reason, they prey onto the abuse of the medication. And then when you do studies, fine and correct is the opposite. But that almost gets lost into the media. So I think it filters down to the medical profession, because I see in our shores come lots of people desperate. You say, can you help me? I've been in 10 doctors, nobody want to give me the Vyvanse. That's why I do the continuous performance test, because in that way I do it objectively. I don't start throwing pills to anybody. I should have said at the beginning, I forgot to tell you, I believe giving medication for psychiatry and any medicine is like cooking. You need to do a little spicy here, a little pepper over here, a little olive oil, rosemary. You don't want to start throwing medications around. So my goal is always the least amount of medication that I can give, the most elegant combination, so you get better with the least amount. Who wants to take medication? So I begin with that point. So when you hear me talking medications or diagnosis or whatever, that doesn't mean that we're throwing pills around. No, I've taken people from medication. But the sad thing is that the medical community have lost or never had this connection with the treatment of the attention deficit, even in children. Pediatricians do a better job about that, but they tend to use a lot of medication, short acting. So the kids never get better throughout the day. We'll talk more about that. So then it's the menace, that's the thing. She said, by the time I think about it, I already did it. And that's exactly right, because and now he's in trouble. See, time out, because because see, you don't have this time to process what I'm going to do. Let's do it. And then when you see all these people, they're so into jumping from planes and they're going to go in the air through the mountain. Oh my God, look at that, and climbing the mountain. Study those people. Most of them at that attention deficit. They feed in the traffic jam. So I need to do that. I need to be living on the fast lane. And then the rest of us look at that and say, wow, but they need that inside. So causes, yeah, there is a lot of things that could happen. The neurological, I told you the TBI, people with a lot of seizures could have that too. And the medication, you can take medication, that is very rare. But yes, if you take a truckload of medication, you look like ADHD, but not really. When you look at zombie, that's what you look, you know, that's not ADHD. The family style and organization can make, I'm not gonna say that create that, maybe I should clear that as a slide for the future. It said that can make the ADHD worse. But maybe if you have a really chaotic family, where everybody's all over the place, maybe those kids might look a little ADHD, but once you analyze them and observe them over time in the classroom or in the evaluation, they're not. That's so the school, the motivation, etc. That general medical condition can do that too. Obviously, if you have a tumor or things like that in the brain, but those are very specific and uncommon. So continue with other causes as well. The psychiatric issues can do that. You see people that start getting early dementia, they might look like ADHD, but it's not. It's something a lot worse. That's another subject for another day. So the learning disability, we talk about that. Stress is very important, no? Somebody in a lot of stress can look ADHD, but it's only temporary through the times of the stress. So what do all these things have in common? And that's, again, go back to my point about the comorbidities, or in this case, it could be either comorbidity, could be things that go along or instead of. But take a look, the whole laundry list that we already discussed, some of them, poor school fit. I have few cases where kids are bullied, so they're really traumatized. I mean, like rats in a cage. The mother is tired and overworked, the father is not even present, and the teacher, she didn't care maybe. That's thinking in one real case, not every time it's like that. And the kid was bullied, so his school grade went down and he came for ADHD. But when you sat him to do the continuous performance test, he was fine. And then I said, you need to look further. No, the teacher said it fine. They kept looking. There was a little kid. There was a horrible bullying case. She went to the district all the way, and they changed her to a new school. There was no more ADHD. He's happy, in peace now. Bullying is a horrible thing. Again, another subject for a whole lecture. So you got ODD, we'll talk about that. Poor hearing. I have two patients. They have bilateral hear problems. They have the device, but still, they test borderline in the test. So what I had to do is give them a non-stimulant. Both cases, the same treatment I gave them. And they weren't in a special school in San Antonio that the parents almost came on their knees. I mean, if they kick it out of this school, I don't know where to put it because it's for deaf kids. And they were about to be expelled. After we finished with the treatment, they both had A's, and they were in honor roll. And it was all about the issue of the poor hearing, which they do have that, and they knew that, all the kids in the school, but they have to be treated a little bit because the hearing, now you might wonder, was it the hearing or he said he has the traffic jam? Maybe it's both. I mean, it's a comorbidity. So the point is, what do all of that has in common? That's it. It could happen. Either they have it together or they're mistaken for it. So comorbidity is the rule, and I already put that slide. I just wanted to remember that slide for you to, at least after you forget the 80% of the lecture, remember this. So the reason for being tested, that is before we came to San Antonio, I've seen some good psychologists doing testing, but I've never seen any physician doing testing, which is sad. The test for attention deficit was made by physicians. One of them, it was the University of Minnesota, the U. It was Dr. Larry Greenberg. He was a pediatrician that turned child psychiatrist. And he's retired now, but his legacy continued. And there's three type of testing. I was gonna say it later, but I said it now. One is the TOVA, T-O-V-A, which I'm gonna show you, that's the one we use. They have the IVA, visual and the auditory, and the Conners, which is supposed to be the most known test. It helps you with the diagnosis. They bring you objectivity, and the patient will have something that they can discuss, they can see, That's so important. And then measure really continuously how you act. They have nothing to do with cognition because it's a little dot in the computer. Or in the auditory, it's two little sounds, a bleep and a blop. Blop, bleep, bleep, blop, blop, bleep, and they keep you in the blop, bleep for 20 minutes. So believe me, it's boring for everybody. But for the attention deficit, it's murder. And they can wing it for 2-3 minutes, but not 20 minutes. And then you see the truth coming out. And then it's really, there's no language involved, so there's no bias into it. This was the medical student, and he was struggling in medical school. He thought he was on a flunk it, and this is an intelligent kid. And take a look. In the x-axis is 1 second. So this is 1 second, and this is about half a second, right? So these are the time that he clicked upon the command. And with the auditory, it's a blip blop, and the visual is a little dot. It's up or down. So I click if it is up, I hold it if it's down, and hold the click, hold the click, and you go into that madness for 20 minutes. So take a look. He only needs to do the same thing for 20 minutes. Press a micro switch. That's it. And take a look. He took all kinds of times to do that. This is the amount of time he clicked. So for example, this bar would say about 28 times he took a 0.6 of a second, so forth like that. Now when he took medication and did the test again, look at what he did. So now he answered most of the answers, hundreds of clicking like a machine, 0.3 seconds, one after the other. And so if I superimpose both, this is the point. On medication, his brain was smooth like a Swiss clock. Without the medication, his brain required different time. It's like the pathway to attain the answer have to be winged every time. So now this is only a test, a boring sameness over and over. Imagine his brain every day in life, when he need to dedicate. So now you are at a lecture, you need to pick it up and do something, and then the brain is going like that, and then all of a sudden, I got it. What was it? I don't know. What was it again? So, because his brain is like that. But when his brain gets like this, then you get it and you move on. If you are in a circle of people in college, for example, maybe everybody got it, you're still trying to say, what was that? Because your brain is working over time all the time. So that's with medication. Take a look at two people taking a test in a school. One of them is the control and the other one is the ADHD. And they're doing a test, right? Look at the blood flow of the one, the control, it's flowing well, not the attention deficit. So that's that. I mean, you don't go around doing that for patients. You know, mostly for the research. We do scales. I use the Jasper Goldberg when the patient come in, so at least I picked up a flavor how they feel with the scales. And then, so I want to put that clear so you understand that the CPTs, the FDA said, is not to diagnose the ADHD. So technically, you diagnose it by clinically seeing. It's an aid, but a powerful one, nonetheless. So this is the TOVA, the one I use, that stands for Test of Variables of Attention. And then it has a lot of test reliability. It's so long, 20 minutes, so tedious. You do it over and over, and they don't get used to it. I had a teenager that set himself in his mind to beat the test. I never told us that. I mean, his dad spent a lot of money in medication and visit to the doctor. So he was throwing all the medications in the back of the bed, and he had a big pile at the end. And then the father found it, and then he confessed that he was trying to beat the test. He did the test like 4 times. Every time was the same. So I said, it's impossible. He taking medication, and the test looked like it never changed. Why can't it keep being the same? He confessed. He said, you know, I recognize now I cannot beat it. And it was like that. So anyway. So, and also there has a symptoms exaggeration. Those people that I see, or I got the feeling like a teenager that wanted to study at 2 in the morning, 1, 2 in the morning, and then the medication never worked enough. I start suspect. When I did the test, I realized he was in attention deficit. That's a subgroup that sometimes is over-amplified with almost the narrative. It's like they got a lot of them doing that. Not really, but some kids do abuse it or do use it for tests. They don't need it, like this guy. And I did the test, and I saw it was exaggerating. So when I see that, I don't confront them. I am not a lawyer or the judge or the police. I just retrieve back quietly into my, I'm going to give you non-stimulants medication. Most of the time, they never come back again. And they honest, they said, I take whatever, and they keep working with me, and then I'm flexible. But so this is the test, you see. I mean, here you got a subject there taking the test. This is the button. And it is so boring. It's going to be there now for 40 minutes, probably fuming. And this is the test. When the thing goes in the top or goes the bottom, you press or you don't press. It keeps flipping. So now take a look. The response time. This is the same thing we saw, for example, with the medical students. So it's pretty much the same thing. How the responses get unified and better. But I do want to tell you about this. Look, the effect of the medication versus the amount of medication. Remember that I told you I tried to do the least possible medication, and this is one reason. If you see a kid that you start giving medication, his attention starts getting better and better. Let's say in here, at this amount, let's call it 5 milligrams, he's doing great. But nobody knows that yet, because his behavior is still terrible, jumping all around the school. So the mother go back to the doctor and said, not good. So the doctor keep giving more medication. The kid is still terrible, not good, more medication. Now he's maybe taking 2 million milligrams. So now he's doing great, like a little zombie. But if you, yeah, exactly. But look at what happened. Go down the line and touch the attention at that level is very low. So what you made was the typical little girl with attention deficit. Not paying attention. She's behaving, and that's what you don't want to do. That's why it's important to be so mindful, to use little dose and test it with either with one of the 3 tests that exist today, so you know where you are. Like with the medical student, you take the medication and then you do the test. So the errors, I don't know if you want to go in this detail, but at least the errors in the test could be errors of commission, when you really jump the gun, you pressing too fast. You get the errors of not pressing because you not paying attention. You can be then also, well, the same, so the post-commission response time, the multiple responses, they can change in cases that they had other issues. I want to go back to that point in another slide. And take a look at this. Remember the medical student again and the variability, how he was all over the place, took the medication, sharpened up. Well, this is the variability of an age over time in females. We get a lot of females, you test them over the ages, and look at how, as a kid, and these are females with attention deficit, the variability of the reaction time, in other words, how the brain cannot be like a Swiss clock. That it's high. As the age goes into the teenage years, naturally gets a little better, medication or no medication. And then as you get older, the variability go up again, probably like my patient, 65 years old, that she was doing wonders with the medication. So the variability, the capacity of the brain with attention deficit to handle the traffic jam, varies. I mean, you get a little better, less. And take a look at this. Follow me on this one, okay? These are two groups of people. They were measured, responders or non-responders of medication treatment. But prior to start the medication, these two groups of people were given the test. And then the attention deficit, okay, a baseline. And then now they take medication dosages. They take one dose and they do the continued performance test. And then you see that some of them really improved, some of them didn't that much. But then you went on to give a medication and treat it for weeks. And exactly the same people that with the test did well are the only people that responded well on medication. The ones on a one-day medication did the test and respond lukewarm, they did lukewarm all along, showing you the importance that the test could have saved weeks of unnecessary medication in the other group. So, and also more is not better. Take a look, this group of people, this is the improvement, and this is the amount of the medication. So the more you give them, the better they did up to here. Once they get this amount of medication, the more medication you get, the worse you do. It seems like when you take medication, I don't know if you know about the mechanism of action, the medication, what they're going to do is they're going to allow the brain to produce and keep more norepinephrine and serotonin and dopamine. That's for depression, bipolar. For the attention deficit, it's all dopamine, except Strattera, that is not a stimulant, that increase norepinephrine, which by some kind of a complicated system go on to the frontal lobe where the traffic jam is and raise the dopamine there too. So in reality, you know, we all love dopamine. You know what raised dopamine? Chocolate. So everybody loves chocolate. Sadly, also, unfortunately, cocaine does that in a million ways. Some people go nuts with cocaine. But chocolate does that gently, so everybody loves dopamine. If you take dopamine out of your brain, you won't be able to enjoy anything. A hot bath, vacation, sex, a good dinner. Dopamine mediates that, but mediates the traffic jam. So if you take medication, the medication it does something simple. Allow your own reservoir of the dopamine to be transported. I call it like I tell the kid the medication is like a mini cowboy moving his cows. I say your cow in your brain is the dopamine. The medication is only the cowboy shuffling your little cows to the frontal lobe. And I draw a little bottle with the bottleneck so they understand why they take the medication. But that's what it is truly. And then when the dopamine gets into the frontal lobe, more of your own, not the medication, doesn't give you anything, just facilitate. So your dopamine clear up, and imagine that from the bottleneck, now you have a jar, open jar. So now your flows goes back and forth. So what happened, apparently, too much medication, too much dopamine, like anything too good is bad, it start getting the detrimental effect, and take a look, you do worse.